say is a success?
How would you define success? My disease is gone, I'm improving, all kinds of different ways you could define success. I ask them, how do you define success? Their answer back to me was infusion in. That's it. They don't follow any markers. They don't follow pulmonary function tests. They don't follow mortality. They follow nothing but the money going in the cash register. So I am an advocate for all the work that Dr. Glassberg's doing, and I'm behind her 100%. Right now we're going to move on with non-pharmacologic management of IPF and ILD. So this is what I get to do every day. I love being able to take care of patients at the point of diagnosis and moving forward. We talked to them, of course, about pharmacologic management. I talked to you a little bit briefly about some of those things. In addition to clinical trials, we move on into things like this. So the most important thing that we can do for our patients is to educate them, right? We talked about educating about the efficacy of the drugs. We need to educate about this disease process. When you tell somebody they have a diagnosis of idiopathic pulmonary fibrosis and you don't finish the story and tell them what mortality looks like and tell them what progression looks like, guess what they're going to do? They're going to go home and do this, right? And they're going to learn it all. So best to learn it from us, right? Best to learn those hard things from us, because that's what helps establish a relationship, a good, strong, trusting relationship. It's a hard discussion to have some of these talks with patients. They did nothing to deserve this disease. But having these discussions with patients up front helps us understand and helps us let them understand that we're here to take care of them, hold their hands through this sometimes bad course. So we're going to talk about expectations. We're going to talk about the medicines. I want them to understand how important it is to wear their oxygen therapy. And we're going to have a slide up here shortly about that. But it's more than just an inconvenience. There's a purpose behind you wearing your oxygen, all right? Comorbidity management is very important. We need to make sure that certain diseases that seem to be married to pulmonary fibrosis are managed appropriately. Patients need to understand about acute exacerbations and what that looks like and what that could mean. And we need to also talk about lung transplant. So we're going to cover those few topics. So every patient that has a diagnosis of pulmonary fibrosis needs to leave your office with a prescription for pulmonary rehab, right? I mean, they do. It's exercise that's done in a controlled environment to make sure they're safe. We need to teach certain aspects about different kind of exercise techniques and breathing mechanisms and things like that, but making sure their heart rate's not getting too high and their oxygen sats aren't getting too low. And that's the whole purpose of pulmonary rehab. There's study after study after study out there for all kinds of lung diseases, including idiopathic pulmonary fibrosis, that shows when you enroll in a pulmonary rehab program, everything gets better. And then you finish and you don't continue exercising and everything goes back to the way it was, right? So it's very important to continue that exercise. Patients can be Medicare approved for pulmonary rehab if they have a restrictive process based on their FVC. There's a nice little chart you can follow based on your height. You have to be a certain liter or less, or based on your diffusing capacity. If your diffusing capacity is less than 40 or 10.5 milliliters, you can be enrolled in pulmonary rehab. So we typically have our patients do that 3-month program with visits every 2 to 3 weeks. The problem with enrolling people in pulmonary rehab is that pulmonary rehab is not on every corner like Walgreens is. So it's hard to get to a pulmonary rehab center. I think it'd be very important, even if we could get them to go to a few things, as long as we know they're exercising at home, that's better than nothing. But if you can get your patients to enroll in pulmonary rehab, it will only do their body good. I always like to make sure patients understand too, is pulmonary rehab going to do anything for your fibrotic lung disease? Is it going to change your what's going on in your lungs? No, it's going to change everything around your lungs though. Oxygen, very, very important that we help patients understand the importance of wearing their oxygen when it's prescribed. As you all know, oxygen typically kind of comes on in a progressive fashion. Early in the disease, they only need oxygen with heavy exercise. And then it kind of progresses to needing oxygen with typical, walking on the level or things like that, and then we get to the point where we need it all the time. We need it at rest and with exertion. Is there any studies out there that show the benefits for oxygen with IPF? I'm not going to do a placebo-controlled trial, all right? Most patients do benefit from oxygen therapy when they're wearing it right, and we've seen that wearing your oxygen will help you kind of slow down the progression of pulmonary rehab or pulmonary hypertension. It's important for patients to be vaccinated and have all those bases covered, so I put up the vaccination schedule up here. Briefly, it's just, you got to make sure you get your Prevnar and your Pneumovax in. Everybody needs to get their flu shot every year. Psychosocial support, incredibly important, and patients report this in surveys. We're all real good about talking about what's going on in the lungs, but we're forgetting about what's going on up here. So remember, early in this disease, even before patients are diagnosed, they're probably pretty dismissive about this hacky cough that they've had for the last year. Don't want to pay any attention to the fact that their shortness of breath is there when they go upstairs. I get short of breath when I go upstairs too, so they kind of dismiss it as, I'm getting older, I'm getting heavier, I'm not as active as I was, and this is why these things are going on. And then they're told in an office visit, you have a bad lung disease, your life expectancy is suddenly very short. So they go from dismissive kind of behavior to, I don't even know how I can look at my future anymore. So very isolated, a very horrible, overwhelming feeling that they don't know where to go to next. So it's important for us to recognize that, talk to your patients about where they are up here. I think it's important that we set goals with our patients as well. Not only short-term goals, but long-term goals as well. So as you all know, you have a goal that you can reach, and if it's a year long down the road, you're going to do what you can to reach that goal. Set another goal so that you have another year to reach those goals. So those goals I'm talking about are, short-term goals might be the goal of getting to the, I always call it the Liars Club. My dad used to go to Dunkin' Donuts with his buddies and sit and talk about my mom and me probably, and I told him, you go to your Liars Club this week? So, being able to do those things they want to do socially with their friends or with their families on a weekly basis, but those long-term goals are, I want to see my grandkids graduate high school, I want to go watch my daughter pitch a baseball game, or different things like that. Comorbidity management, just to give you some of the numbers associated with that. For respiratory comorbidities, obstructive sleep apnea can be as high as 48% of the population of our patients. Lung cancer is equally as high. Pulmonary hypertension can occur into up to 86% of our patients. COPD, of course, is very high as well. For the non-respiratory comorbidities, we have GERD and heart disease. So all of these studies kind of are dependent on who's the author and what the center is, where they're getting these numbers at. But these are common comorbidities that all need to be managed well. Sleep apnea, of course, needs to be managed with CPAP or BiPAP. Lung cancer needs to be out of there. It needs to be resected, or we need to do some marker studies to see what medicines we can use to treat lung cancer. Pulmonary hypertension, there's no medicines, of course, that are approved to treat pulmonary hypertension related to interstitial lung disease, but we can manage it better with knowing that it's there and making sure patients who are lung transplant recipients get transplanted quickly. And I'm going to talk to you a little more about GERD here in a minute. The important question you need to ask your patient for lung transplant is, do you ever want one? I've heard Dr. Jim Lloyd say that more than once. Do you ever think you'll want a lung transplant? Because if the answer is yes, then we need to work on that now, right? So do you ever want a lung transplant? Not today, but maybe in the future. So think about those patients that you have that have this lung disease that might meet some of the common characteristics required for a lung transplant. What is their age? What is their weight? What is their tobacco use? Don't forget about smokeless tobacco, all right? So those three things need to be looked at, and you need to know your closest center's requirements for lung transplant. So look those places up. We don't always get to go to the closest center. We're kind of we're kind of tied to insurances as to where we go for lung transplant, but know those centers' requirements so that you can engage your patient to seek those centers out. Encourage your patients in weight loss, encourage them in becoming smoke-free or tobacco-free. As you know, the do you ever want a transplant can change. It's important for patients to be educated about that. So we encourage them to go to lung transplant support groups. But as I tell people before, who attends support group meetings? Like, who's here now? People that feel good, right? You only see one half of the lung transplant support group. You see the people that feel good, you see the people that are living. So it's important for patients to understand there's a whole other side to lung transplant that they're not going to see typically in a support group meeting. But it's important for them to go and talk to people that are going through that process. Palliative care basically is nice words for symptom management. It's important for us to get started on palliative care. At Vanderbilt, we have a good outpatient palliative care program, and involving our patients in that palliative care program is important. So palliative care program can of course help us manage dyspnea, cough, fatigue, and depression, but all of these things can be managed with oxygen therapy, pulmonary rehab, weight loss, and making sure we're checking in with the patient mentally on a regular basis. So for follow-up, we want to make sure we do, your kind of typical follow-up routine. Every 3 months is what we see patients at Vanderbilt for, and we're going to do pulmonary function studies and 6-minute walks, primarily to see where they are on their lung function and what kind of oxygen loads they need to be. But the most important question you can ever ask patients when they come in at their 3-month visits is, how are you doing? How are you feeling? Where are you at with your goals? Are you meeting those things? So one other thing we like to do, our patients come from a 7-state region, so we like to share our patients, of course, with their referring physician. We don't like to take full control, so to speak, over all of them. So maybe sharing those visits every 3 months, especially if it's difficult for patients to travel. Now, I guess that's it.